One, two, three. You are live.
Hello, good evening, everyone. This is Mondi Effie. I will be taking you through hemodialysis. This is our live broadcast, day two, and I'm happy to join you in and kindly have a year to listen to us for the good news we're gonna bring today for all about hemodialysis. Thank you. So today we're going to tackle topics on introduction, briefly, the brief history of dialysis, principles of dialysis, goals of hemodialysis, effects of hemodialysis, indications of dialysis, the access points we use during dialysis, and we're also going to talk about nutrition therapy. Brief history of dialysis. So the history of dialysis dates back to 1940s. The first type of dialyzer, then that was called artificial kidney, was built in 1943 by physician Dutch William Kolff. He had forgotten the idea of developing a machine to clean the blood after watching patients suffer for kidney failure. When his invention was completed, he attempted to treat over a dozen patients with AKI for over next 2 years, but it didn't go so well. Only one patient, he was only able to serve one patient with the invention. And at around 1962, Dr. Beldin Kidner developed some portable machine that allowed patients to dialyze even from home. Yes. The current situation in dialysis right now is showing that over 90% are receiving treatment from home, and even more options are upcoming, such as peritoneal dialysis and more hemodialysis here can be done at home. So, brief introduction. Kidneys are one of the vital organs for survival. A healthy kidney is responsible for cleaning our blood, getting rid of excess salt, water, and toxins in form of urine. They maintain the body acid-base balance. They also produce vitamin D3, yes, and erythropoietin hormone, which is helping us cover anemic situations. Every day, these organs, the kidneys, they cleanse our body's blood about 300 times daily. It's a process that is ongoing daily and daily, hourly and hourly, after every second. Around 30 times, 300 times, your blood flows through the kidney. If the kidneys become diseased or fail at any point of life, it becomes a serious problem because the wastes and toxins can no longer be filtered out, and your system now will be like so squeezed, like someone maybe in a hotel California where you get in but you can't come out. So all the toxins that are in your body are retained there when your kidneys are not adequate. We continue. So a reduced function is due to conditions like infections, injuries, restricted blood flow that is due to low renal perfusion. So those are the causes of reduced renal function. When there is reduced renal function, it can lead to excess accumulation of toxic wastes and fluid in the body. This thereby causes many complications that come along with accumulation. For example, hypertension. When your body is full of overload, your fluid is retained in your system, the pressure in your vessels increase, therefore causing hypertension. Can also lead to complications such as heart failure, pulmonary edema because of the overload. It can also lead to metabolic acidosis, hyperkalemia can come in, and all these, when they continue, they can lead to death. Hyperkalemia is like a silent killer. When your body retains too much of potassium, it can lead to arrhythmias, and this can disrupt your ECG and can lead to death and coma. Yeah. So as we continue, the treatment options of kidney failure include dialysis and also kidney transplant. When you have renal failure, um, you can have these options of joining dialysis, where we have peritoneal dialysis and also the hemodialysis. A good option also is kidney transplant, where now you fully transit to a well-working kidney, a new system altogether. Yes. So dialysis is an artificial process that partially replaces renal function. It removes waste from your body by diffusion, and the diffusion helps to clear the toxins. It also removes water through ultrafiltration, yeah, to help maintain your fluid balance in your body. So water passes into a special liquid dialysis fluid, which is also known as dialysate. I'll explain later on. So we have principles of dialysis, overall principles of dialysis as a whole, combining both with the peritoneal dialysis and the hemodialysis. The net removal of uremic solutes is influenced by these principles that I'm going to list for you. We have a concentration gradient for the diffusion. We have the diffusibility of that solute you're using. Another principle is permeability characteristics and surface area of the membrane. You know that the more porous it is, the small pores, the more effective your your membrane will be. Uh, Another principle is blood and dialysate flow within the dialyzer. The flow is always countercurrent in that when one flows in a downward direction, the other one will be an upward direction to achieve that pressure. And then another principle of dialysis is also the duration of dialysis. That is time. We have mostly a period of 2 and above 2 to 4 hours of dialysis. So the more time in a dialysis session, the more effective you'll clear your toxins. The next principle is also distribution volume of the solids. And another principle is amount of ultrafiltration. Yes, so we have types of dialysis. Dialysis is of two types. We can have hemodialysis and we can also have peritoneal dialysis. But today, our presentation, as you see up there, is about hemodialysis. We're going to concentrate majorly on hemodialysis as it's the most widely used form of dialysis in Kenya or maybe worldwide. So hemodialysis, it is also known as an artificial kidney. When your kidney function reduces, we got an invention back there from our history, yeah, that we have an artificial kidney that will work exactly as your kidney, though not 100% as the natural kidney works, but it's an improved way of making sure that your system clears all the toxins and the waste that are accumulated. Hemodialysis is a form of renal replacement therapy that is most widely used here with the end-stage kidney disease and patients with renal failure. It's mostly started when your EGFR, when your glomerular filtration rate is less than 15. So hemodialysis is usually done 2 to 3 times in a week in most of our facilities. Yeah, and two times in a week is affordable to many. Yes. So each treatment lasts for 2 to 4 hours. Whenever a patient is set on a dialyzer and a dialysis machine, the time limit is always at 4 hours so that the patient can have an effective clearance. During treatment, the patient can read, the patient can write, the patient can sleep, can watch TV, can talk. It's a normal process here. She or he can continue doing other things. Parts of hemodialysis system, whatever we use for the whole setup. We have a dialyzer that is now the artificial kidney. So about um, 30 centimeters long, around 12 inches. I hope most of you have seen it. Yeah, and then we have a blood compartment, the tubings here that carry blood from your body to your from your body to the machine, and then from the machine back to your system. And those codings, they are codings, the red and the blue. I hope you've seen them. We also have the semi-permeable membrane. The semi-permeable membrane is in that artificial tubing, the cylindrical tubing, that centimeter cylindrical tubing that we use as the artificial dialyzer. We also have dialysate, the dialysate solutions that are used here to attract those extras into the fluid and then out of your system. We also have vascular access routes. I'll show you ahead here, I'll show you the access routes available. They are used. We also have a HD machine as a whole where the nurses help us to set the patient. So hemodialysis process occurs outside the body in a machine as compared to the peritoneal dialysis where your patient is set to sit at a position where the fluid, the dialysate, is allowed to dwell in your peritoneal cavity. In hemodialysis, the process works out of your system. The blood will get out of your system to be cleansed and then back to your system. Inside the plastic tube, the 30 centimeters, the artificial dialyzer itself now, the blood flows through around 20,000 hair fine fibers. The fine fibers have microscopic pores, and they fill out metabolic wastes and excess water. So that's actually what happens in the tubing. I hope you understand, though I don't have a demonstration on that, but I hope you've seen the artificial kidney, the way it looks like. There are some tiny, tiny poruses here in the artificial kidney, around 20,000 of them that help you, that work as uniform, help you filter your waste. As the blood cleansing process proceeds inside the dialyzer, a dialysis machine pumps the blood, administering anticoagulants such as heparin. It's the most commonly used, the IV anticoagulant, to ensure that there are no blood clots that might form during the circulation. Yeah, follow along. We are going to the principles of hemodialysis, the concepts of hemodialysis. We talked on principles of dialysis as a whole, and now we're going to talk of the principles of hemodialysis, the concepts that help in hemodialysis. There are only three major concepts of hemodialysis. The first one is diffusion. These concepts help to during ultrafiltration and all. So the first one is diffusion. In diffusion, molecules move from a region of higher concentration to a region of lower concentration. I can give an example of this by when you spray a perfume next to you. Who hears it first? The concentration is from here and then it diffuses slowly to other places. Yeah. Maybe I would love to give such an example. So diffusion also occurs during hemodialysis, yeah, where the molecules move from a region of higher concentration, which is your blood, to a region of lower concentration, which is the dialysate now. So when your waste, the toxin and the waste get to move from your blood into the dialysate, we will achieve that maximum filtration. Another principle, another concept in hemodialysis is osmosis. Osmosis is all about molecules moving from a region of lower concentration to a region of higher concentration solute. In that water will move from a region of lower concentration solute like blood, to a region of higher concentration solute, which is the dialysate, through the semi-permeable membrane, which is at the artificial fitting. Yes. So another concept we have is the number 3 concept. I hope you're following along. We had diffusion, then osmosis, and then we are at ultrafiltration. So ultrafiltration, water moves under high pressure to the area of lower pressure. As we said, the flow is always at a counter current. The blood enters and then the dialysis solution from below. You understand? So those are the three major principles, three major concepts of hemodialysis that help us achieve that effective process. Indications of hemodialysis. There are those indicators that will, let's say, that will be used, that will be used now to get a patient to a stage of starting dialysis. There are some patients when you don't have such indications that I'll mention, they are not eligible for hemodialysis. So the indicators that make a patient eligible for hemodialysis are the RAEOs. You can remember the RAEOs. So the R, the A, the letter A for apple is acidosis. Metabolic acidosis basically is the first indicator for a patient who really needs hemodialysis. And then we have electrolyte imbalance, where now we have the hyperkalemia, hyperphosphatemia, the hypernatremia, the electrolytes are just all over the place. And then we have injunctions and toxicity. That is also an indicator for hemodialysis. We also have fluid overload. Fluid overload, you can assess this by maybe pressing, doing your pinches and the presses at the knees. You can see at fluid overload with the puffy faces. Those are how you can check for the fluid overload. So when you press at the knee side and then you see a hollow, a depression, you check for fluid overload. That doesn't rise up after 3 seconds. Another indicator for dialysis, hemodialysis specifically, is uremic symptoms, uremia. Okay. Yeah. So we're moving on to goals of hemodialysis. So hemodialysis has two major goals. Number one goal is to clear the solute. This is achieved by diffusive transport, which is based on countercurrent flow of blood and dialysate and solvent drug of ultrafiltration, as I explained the concepts behind there. So the goal is to achieve solute clearance through the concepts of hemodialysis. Another goal of hemodialysis is to achieve fluid removal, effective fluid removal. Yeah. Effects of hemodialysis on lifestyle. Once a patient is on hemodialysis, nothing is normal. We will say nothing is normal. It's not the way of life actually. So some factors are disrupted. Yes. So for example, when a patient starts hemodialysis, your doctor says you'll be attending your clinics in the unit twice in a week, maybe on a Thursday, and then you come back on another Tuesday. Every week you come twice. There are many disadvantages that come with it. Apart from financial issues, we also have reduced level of participation and productivity. Um, you can't do your exercises as you used to do. You can't participate in sport, those vigorous sports. And also when you have your fistulas placed on you, you have the catheters, there's some level of interference with your self-consciousness due to how you view yourself, your body image. Yes. And then travel inconveniences. You have to travel maybe from far just to go, and twice in a week you just have to go and do your session every twice in a week. So those are travel inconveniences that happen. You have to struggle around also booking and maybe acquiring those equipments that are needed. There is also an effect on the sexual activity of a patient because this patient now lives with a lot of anxiety now that the renal failure comes in. So they also need real support, both social, both psychological. They really need a lot of support in that. Yeah. Moving along, we have the preparations for dialysis. There are those preparations that have to be made so that we have a successful dialysis session. The number one thing that must be prepared so well is make sure your patient has the good access of circulation. This is through you. Make sure you have a fistula, or maybe arteriovenous graft, or a catheter. I'll show you right ahead where they are placed. You also have to ensure that you have good cardiovascular status. The BPs, you must check them and ensure that your patient is at a good blood pressure level. You have the dialyzer set in order. You have the fistula need, you have hemodialysis fluid, the bicarbonate powder, you have the IV set, the injections for dextrose. That is in case of diabetes, uropathy, diabetic nephropathy. Also ensure that you have the normal saline. Yeah, the normal saline that you'll flush the whole system with before you start dialyzing. You must ensure you flush the whole system. We also have injection, heparin injection, as I said, I mentioned earlier. Yeah, it helps you avoid the clotting that might form during the process. The syringes are also set in order, yeah, that will help you draw whatever you need, if it's the antiseptic, if it's the saline and all. So we have preventive measures. How you prevent bloodstream infections in hemodialysis patients. Whenever you have your access, yeah, the process of hemodialysis, it's a very sterile procedure, and it's mostly associated with a lot of infections coming along, and peritoneal dialysis having major and higher risk of infection. And again, the hemodialysis also has a lot of infections that might occur. So to ensure that you prevent all these, there are various things you can do. You can make sure that you have good hand hygiene. Hand hygiene, the five processes here. The five maybe steps or periods or times that you have to make sure you have good hand hygiene before you see a patient, after you touch a patient, coming into contact with the body fluid. Yeah. So you can either wash your hands with soap, that is when your hands are really soiled, or you can use sanitizers. Maybe you just come from removing your gloves, and then you can now sanitize. Another way of preventing infections is also by protecting the vascular access sites. Yeah, you can care for your access sites by ensuring that you use antiseptics. You don't just touch them. Have you seen the nurses unit? You just have to make sure that the vascular access sites are really taken care of before you do your connections. Make sure you you do the sterilization. Make sure everything is perfect. Another prevention of infection also comes in by making sure you do routine disinfection of your dialysis station. Either it's a big place, maybe it's a small place, but make sure you do some thorough routine disinfection of your station. Yes, I was to talk about the access points that we have. Hope you're following along. Yeah. So we have three major access points that we use during hemodialysis. The number one access point is arteriovenous graft. arteriovenous graft, a surgeon connects an artery to a piece of some soft tubing that acts as a vein, yeah, below your, under your skin, the superficial layer of your skin, on the either upper arm or your lower hand, and a graft is fixed there. So it's easier to create. Maturation time of the graft takes around 3 to 6 weeks. Um, yes, so yes, oh, it's okay, it's okay. So another another access point we have is fistula. That one was a graft. Now we're having arteriovenous fistula. It's different from the graft. A fistula is where now um, the doctor joins a high flow vein, a high flow artery to a low flow vein. We know that veins don't carry blood flowing under high pressure like the arteries. So these two are the fistula is made by connecting an artery to a vein, and it's actually the best choice for hemodialysis because it has optimal blood flow and lower chances of infection. Number three of our access points are the temporary option catheter. Temporary option catheter is placed just right here below your subclavicle region. Yeah, or another one can also be placed in the IJ catheter, just at your neck side. The procedure happens at the theater. Yeah, it's a long Y-shaped tube that is placed at those regions that I've just mentioned at your groin, and connected to the central vein. The central vein. All right. I hope you understood the difference between the three. So we have time to use of both of these accesses. We have fistula, we have graft, and we also have catheter. They have different times of use. We're gonna start with a fistula. Fistula is has an optimal blood flow. As I said earlier, it's best for hemodialysis. It has lower risk of infection. Um, it can take a period of 2 to 3 months for healing. And we have a graft. A graft is a second best choice for us, though it easily clots than the fistula, but it has a slight healing time than the fistula, which takes 2 to 3 months and above. We also have our number three time to use catheter, the temporary one. It has a slower blood flow. It has a high risk of infection. You remember it's placed on your central vein, so major disadvantage of it is higher risk of infection. It's used when your blood vessels are not so strong. Yeah, and yes, I think that's okay. That's okay. So all this process, there are some acute complications that always happen. Examples of them is like hypotension, severe low blood pressure that occurs during hemodialysis. It's the most common of over 20% of reaching to a level of 55% of occurrence. We also have nausea and vomiting. We also have headache, cramping, itching. We have chest pains, fever, and chills. So these are most of the acute complications that happen with the dialysis. I hope you're following along. So we're moving on. We're going to the procedures, maybe we say the steps that before dialysis you have to ensure that you do them, you follow them so well. Number one thing, you must assess the fluid status of your patient. Fluid status can be assessed by comparing weights. Yeah, the weight of your patient before and the current one. The last period your patient was in and that exact weight that your patient has there. Another way of also assessing your fluid status is also by doing your vital signs. Another thing to do before dialysis is also ensure you assess your fistula if it's very effective and efficient. This you can do by you do a feel. You feel if you have a graft at your maybe upper or lower arm, you do some filtering. You listen so that when you touch it, you should be able to hear some good contraction because blood flows there really at a very high pressure. So you must listen for that vibration to see whether it's adequate. Another thing before dialysis, you hold your medication. Medications are like antihypertensives. The antihypertensives, we have a fellow colleague who will be presenting on that. So we have antihypertensives and also the washables. We hold meds because they can be easily washed during dialysis because when you take them, they are washed away easily during dialysis. These are examples of water soluble vitamins. The C, the fat solubles are a DEC. So the other CB vitamins, you make sure they are washed out during dialysis. Another medicine to hold is also antibiotics. Yeah, those are the medicines also to be to be held. But you're allowed to give IV heparin, yeah, the anticoagulant. You are allowed to supplement your patient with calcium supplements to lower the phosphorus levels, and also insulin. Insulin before you do your dialysis, you can also give your patient that because it's easily absorbed just before you begin the process. We have deadly complications that might occur with hemodialysis during or after the session. There are major complaints that might come along. For example, the DDS. That those are the dialysis disequilibrium syndrome. The syndrome where solutes are removed so fast from your blood. The clearance is so fast that can result to edema. The brain cells swell with fluid, and this can increase the intracranial pressure to the patient. Another deadly complication comes in with okay, when the pressure sets in your brain cell, this can this can lead to coma and coma to death. So the patient appears with symptoms like restlessness. The patient might appear so disoriented, vomiting here and there, headaches, but you don't give medication for them because we said earlier you hold medications. But what best action you can take is to stop or you slow infusion and maybe call for help. You call for the doctor when you see such signs. When you clear so fast, this complication comes in. So the best option is to make sure you slow down the process of clearance. Yes, so there are various points you have to consider also, like patient education. You must educate your patient who is on dialysis on certain issues that are very important. For example, how your patient will care for the fistula. How will you let your patient know what's happening? You must explain to her or him how the fistula was made and how to care for it so that it develops. Because if it takes a period of 3 months and maybe he or she doesn't know how to go about it, it's going to be a problem. So you must also help your patient to know how to care for the fistula, or you tell him or her to squeeze or grip a rubber ball. There are some stress balls that they always use, yeah, to make sure that you press them softly so that you develop your fistulas. You also tell your patient to avoid pressure at all times. Pressure comes from restricting fitting clothes, watches on the arm, the creams and lotions that your patients will apply, the the pressure checks that are involving that arm. So those are the things that you really must have a watch on. You also have to tell your patient to monitor any sign of infection that will appear. The redness will show infection. You also tell your patient to report any form of bleeding that might occur. And thrills, the patient must be able to listen to those thrills, the vibrations. Yeah. And also tell your patient not to lift heavy weights more than 5 lbs of weight, carrying pouches and walking around with the heavy weights on that arm. Yeah. So we have things to watch also during hemodialysis. Is like the intradialytic weight gain. Intradialytic weight gain is basically that weight, that weight between the dialysis sessions, the dialysis treatment. So there, how you interpret those weight gain. If your patient gains more than 5%, it might reflect the excessive fluid intake, leading that can lead to edema, ascites, pleural infection, effusion. So make sure you do your calculations well. Educate your patient on fluid intake, restriction of salt, and all. We'll talk about nutrition therapy in coming field. And also, another indicator for intradialytic weight gain is fluid gain of less than 2%. We have just talked about fluid gain of more than 5 that might show maybe your patient is taking a lot of what he or she should take. We also have fluid gain that can be less than 2%. Less than 2% reflects minimal fluid and food intake. Maybe your patient ain't feeding so well and is losing a lot of muscle. So you must also check on the two, yeah, to make sure the intradialytic weight gain is positive. Yeah. So moving along, that's basically more on hemodialysis. We also have nutrition therapy, the management of nutrition management therapy in hemodialysis. There are requirements that your patient take, some things you restrict. Yeah. So a patient who is on dialysis has a way of feeding. There are things you must restrict so that you don't worsen up the situation or progress the injury of your kidneys. Recommendations are as follows. You can have a side note or somewhere. Energy intake, that is between 30 to 35 kilocalories per day. You can calculate that depending on the weight of the patient. Then proteins is quite high because of many losses that come with hemodialysis. Uh, it's at 1.2 to 1.5 grams per kg per day. Yes, and 70% of it should be high biological value protein. Okay, yeah, hope you're following along. Someone kindly check your microphone, and then we also have sodium intake. Sodium intake, you take 2 to 3 grams a day. Sodium now, when we talk of sodium, this is what will control your pressures. When you take in more sodium, your body will uh, will uh, will accumulate more of your fluid because water has a tendency of following sodium wherever it is. Just like when you take some, when you want to kill the slug that the sister to snail, what do? You just pour some salt and it shrinks, it's dehydrated, it shrinks. It means that all the water tend to follow sodium. So kidney function is has a rule of water following sodium. So whenever you take a lot of sodium, your body will definitely have more accumulation, more overload. And then potassium. Potassium, as we said earlier, is a silent killer. It's something you must also watch out for. And the restriction is 800 to 1,000 milligram, not more. Another nutrient to consider is a mineral to consider is phosphorus. The phosphorus intake is 800 to 1,000 milligrams uh, per day. And when your patient takes phosphorus-rich diet. You must also ensure your patient is adhering to the phosphorus-binding drugs, because a higher phosphatemia, the hyperphosphatemia has other disadvantages that come along, like osteodystrophy. Your PTH hormone will rise, and then there will be your system, the parathyroid hormone will be depleting your calcium in your bones. A colleague will also expound on that, so make sure you follow along during our 2 weeks presentation, so that you get to understand how parathyroid hormone and phosphorus and calcium balance is all related. So calcium also is a nutrient of concern. The intake should not exceed 2,000 milligrams per day, preferably taken with vitamin D3. Water-soluble vitamins are also lost, as we said earlier, they are lost during dialysis, so they must be supplemented. So that is the basic outlook of all that. And as we continue, we have practical approaches that help you lower potassium, that help you lower your phosphorus levels. We're gonna start with potassium intake, the practical approaches that will help you lower your potassium intake, so that you don't end up with hyperkalemia. So it's a category of three. The potassium content is categorized into three. We have um, low. Okay, we're gonna start with the richest sources of potassium: fruits. We have low potassium fruits. We have medium potassium fruits. We have high potassium fruits. So you're asking yourself, how do we classify them? Like, how do we say that a fruit is low potassium? How do we classify a fruit as a medium potassium? How will I classify a fruit as high potassium? So when I say a low potassium fruit, I mean the amount of potassium in this fruit, and this can be categorized as 20 to 150 milligram per serving. And the allowed intake of low potassium fruits is 3 exchanges daily, 3 exchanges per day. And then we're moving on to medium potassium fruits. Medium potassium fruits have a potassium content of 150 to 250 milligram per serving. So you can always check on the potassium content before prescribing to your patient the type of fruit to eat. The allowable intake of these medium potassium fruits is 2 exchanges daily. We also have high potassium fruits. High potassium fruits have this range of 250 to 500 milligrams per serving. So the allowable intake is 1 exchange. Though Kenyans, let's say Kenyans, when you tell them to take your high potassium fruits, maybe the doctor, she will be like, or he will be like, the doctor said I can take them. So ending up with the excess intake of what shouldn't be. So advise your patients to take low potassium fruits. I'll mention them. Yeah, and the exchange is 3 per day. And they should be taking them not as a blended fruit altogether. Take one fruit at a time. So we have now the selected fruits based on potassium content. As I have explained before, we have the content of potassium per fruit, right? So I'm gonna explain to you, maybe tell you the categories, where does which fruit lie, but not all the fruits, the common fruits around. So we have low potassium. We're gonna start with low potassium fruits. So low potassium fruits are like the mangoes, the pineapple, tangerines, sister to machungwa, sister to orange. And then we have the apples, we have watermelon, we have pears, we have lemon. Those are low potassium fruits that when in season you can prescribe to your patient. We also have medium potassium that's allowed. Two exchanges allowed. You can give your patient papayas, you can give your patient oranges as a medium potassium fruit. You can also prescribe, sorry for that. We also have high potassium. High potassium now, maybe you can prescribe it for some 5 days when your patient is having hyperkalemia. These things you only prescribe depending on individualized care, because when you say it's equal platform, I give this patient this, I give this patient the same thing I'm giving this other one, it's gonna be a messed up. Everything you prescribing to your patient, make sure it matches the lab values of your patient. So maybe your patient is hyperkalemic or hypokalemic, so you will prescribe this according to your patient lab values. So high potassium fruits, back to the session of potassium category, we have high potassium fruits. These include passion fruits, guavas, bananas, avocados, jackfruit. We'll have a presenter also on that to talk about the CKD diet, and also keep on following so that you enjoy the good session coming along. Yeah. So apart from all that fruits intake, we have cooking methods. Cooking methods that you might employ for a patient. Um, for example, cooking for vegetables, yeah, and also the proteins, the meat, anything you're cooking, anything you're prescribing to your patient. Anything means the vegetables, we're talking about the vegetables and your legumes, your meat. Whenever you're cooking, boiling is really important. Prolonged boiling in large volumes of water, so that we achieve the maximum lows. And also for your vegetables, we advise for leaching. Leaching is the process now where you cut your vegetables into very tiny, very tiny. You cut them tiny, and then you dip them in a hot boiled water for about 10 to 15 minutes, and then now you can drain the excess water and cook them as desired, but not with too much tomatoes, because tomatoes also have high potassium and phosphorus. We also have prolonged soaking of beans, let's say legumes, for example, the beans. You don't restrict something like this. You don't tell your patient, don't take beans, it's gonna harm you. But you can also tell your patient to take beans, but after preparing according to how you would have advised. So we always tell them to do some prolonged soaking, maybe overnight. If you wanna cook your beans tomorrow, you just soak them overnight today so that they sleep in water and maybe start fermenting, and then cook them. After cooking them for 30 minutes, you discard the water, and then you cook again until it's well cooked. So those are also the best ways of ensuring that you achieve maximum losses of minerals you don't need, like potassium. And then avoid using things like pressure cooker and microwave. But you can reheat your food when it's cold. You can reheat it, but you don't use a microwave to make it hot. You limit portion sizes or quantity of potassium fruits and vegetables accordingly. Yeah. So we have another nutrient of concern that we're gonna talk about, that is phosphorus. So hyperphosphatemia is also common with patients with CKD, because when we have an overload accumulation, the potassium and the phosphorus have a tendency of becoming so high. So we have to manage your hyperphosphatemia and hyperkalemia. So we talked of management of hyperkalemia. Now we're gonna talk of hyperphosphatemia. That to ensure that there are no osteodystrophy, your bone losses. Okay. So this you can ensure that your patient takes a low potassium. The sources should be of low phosphorus, and then taking meals with potassium binders. Yeah. So another thing you can also advise your patients to do is avoiding additives, phosphorus additives. Additives, you can check the labels, the food labels, but it's not so easy to find your phosphorus labels in your food products, but it's good to check. Make sure you check your phosphorus. Yes. So that will also be explained here coming along with the different panelists. Yes, so we're moving along and we're gonna talk of parenteral nutrition. Parenteral nutrition in intradialytic. During the session of dialysis, we can also do our parenteral nutrition. So intradialytic, meaning within the dialysis session, you can is provision of nutrients through the venous drip chamber while the patient is undergoing hemodialysis. So it applies to patients who are malnourished, critically ill, and hospitalized patients with CKD, kidney failure, and are on hemodialysis. So it's important that when your patient has above malnourished, the intake is not adequate, you can always ensure that you offer the parenteral nutrition during dialysis. It's very, very possible because the content of the fluid, the parenteral nutrition, does not in any way affect the volume of fluid during dialysis session. So this will help a patient reverse catabolism and maybe add some weight, achieve intake, so that we ensure we really reverse catabolism. So indications for intradialytic parenteral nutrition is for patients with moderate to severe malnutrition and maybe gastrointestinal disorder, those with inadequate oral intake, failed attempts to increase nutrition status, yes, or maybe a candidate who is not fit for tube feeding. All right. So we have, continuation of that for a typical 4-hour dialysis session. So the session is a 4-hour thing. So within it, you can initiate parenteral nutrition, the intradialytic parenteral role in nutrition at the beginning of the run when you're starting the process, the treatment. You can also start your um, IDPN so that it runs through up to the end of 4 hours. You don't give bolus. You just give it to run slowly at a lower flow rate. Um, Also, once you're done with the process, the time elapses. You just discard the remaining solution. You discontinue. Don't go on with it. That will also be explained upcoming with a colleague. So keep on checking. So our time is within. Sorry. So in summary of all, learning is a continuous process. You keep on learning each and every day. So in summary of all this that we talked about, um, located on each sides of the spine, yeah, just at the lowest part of your rib cage, we have these bean-shaped organs, which are the kidneys. They play a very important role in a very important role, a very primary function that ensures that your body filters all the waste products, excess water, blood impurities. When you do, when you your liver detoxifies, your kidney is the one responsible for ensuring that your system clears it all. So when these functions are disrupted or you lose your ability to filter the blood, it means, sorry for that. Um, when these functions are disrupted, you lose your ability to filter blood. patients are always left with only two options. It's either you go for dialysis to remove your accumulation, or you do a transplant that will restore a normal function. So hemodialysis basically is a proven effective management of kidney failure. It's very effective in managing kidney failure, and it has really helped a lot of patients. It has really progressed life, and we give a thumbs up for that. So within the two options, your patient is still free to choose either of the two options. He or she can choose peritoneal dialysis, or can choose hemodialysis depending on which best will suit them. Yeah. So basically, that's the perfect summary of today. Uh, thank you so much for following along. I appreciate so much. So I was your presenter, Effie. Thank you.
Um, Thank you, Effie. I want to um, invite Priscilla to continue from here. Priscilla? Kindly turn on your cameras. We have a small panel discussion. Susan, we're waiting for you. Okay. So, Priscilla, take it from there.
Thank you so much, Effie, for that wonderful presentation. I believe we've all learned about hemodialysis, so we want to welcome comments, questions from the panelists, and I think I want to begin. As Effie has talked about hemodialysis, so we as nutritionists, we need to individualize care for our patients so that we don't do a blanket, care for patients. And this individualized care will come from, you know, our assessments through probably the biochemistry, as we had talked yesterday, where you look at the lab works of the patient and see if the patient has high potassium levels. You need to, cancel accordingly. You will find another patient has low potassium levels, hypokalemia, then you need to address it differently so that the renal care is not a blanket care. It is so personalized. And I think that is a very, very crucial point for everyone, for all the nutritionists to know that renal care and renal counseling as nutritionists should be so individualized. Another point maybe I want to talk about is the IDPN, the intradialytic parenteral nutrition. Yesterday we talked about an assessment tool, which is the SGA, and as Effie has said, we need to know that if our patient is malnourished, then we need to use that tool to categorize the malnutrition, so that you know which supplement to use. Let's take, for example, the best supplement to use maybe intradialytically would be a supplement like nephrosterol and not aminosterol. So we need to have, that knowledge of what to use when. And critical thinking also comes in here, because you as a nutrition, you need to analyze, the patient, know when to do what and whether it is safe or not. So I think that is my point. I would wish to welcome anyone else who has a comment, a question, or something to add. You're welcome. Anyone?
Maybe I can just say that thank you, Effie, for the presentation. It was nice, it was informative. Yeah, thank you.
Uh, Good evening, everyone. This is Evelyn talking. I wanted to know how frequently do you do the lab works for the patients coming for hemodialysis sessions in your different facilities? And also, I didn't clearly get the fluid intake for patients going for hemodialysis. I didn't, or maybe it was said, but I didn't get it well. The fluid intake and how do you gauge their fluid intake for the patients going for hemodialysis sessions?
Hi, Evelyn.
Yes.
You want me to expound on the nutrient requirements?
Not really. How often do you do the lab works? Like for instance,
Yeah.
knowing of the HB levels of the patients, knowing of the potassium levels of the patients that you are undergoing hemodialysis in your facilities,
Yeah,
and
so
any
I would
other.
give an example of, sorry, I would give an example of this facility that I was in. They usually do their lab requests every session a patient comes in.
Fluid requirements for patients, the SCAD patients.
A patient undergoing hemodialysis, you must really consider the fluid requirements in that, depending on the fluid overload of a patient. It's individualized, personalized care, so that when you really have severe overload, you are allowed to do an output. You do your urine output. Yeah, you make sure your patient measures all he or she is gonna remove for a period of 24 hours. So if there are a lot of overload, you do output plus 300 mLs. And then when we don't have severe output overload, we do an output plus 500 mLs in hemodialysis.
Let me just clear some points there. One that you talked about fluid overload. Normally, when you are starting the discussion, you told us about the kidney functions, functions of a normal kidney, and one of them was fluid balancing. eh? So when your kidney is
Yeah,
compromised, obviously it will not balance the fluids in your body. So depending on the
yeah,
stage at which the patient is in,
yeah,
especially the end stage renal disease and the CKD, most of them they may
yeah,
present with anuria or oliguria. So you've explained well. You
yes,
check the 24-hour urine output, and then there's that allowance
yeah,
that you give the patient. Sometimes you can do 24-hour
yes,
urine output plus 500 mils of fluid,
yes,
or when the patient is severely dementious, you can
yeah,
give 300 mils fluid. uh,
Yes,
allowance
that's
would
exactly what
require you
I
to take.
explained. Yeah,
Yes, that's a
yeah,
good one. Then, when you are
yeah.
talking
That's
of the indications for hemodialysis, we you said
yes,
of the RAOO. Uh, it's not a
yes,
must that the patients should present with all the IAOs, but at least one or two
yeah,
of them. If maybe the patient is only hyperkalemic, they can
yeah. Sorry, I
either
didn't hear
choose
you.
to bind disease. So that also matters. You don't have the indications in a patient for the patient to go for the hemodialysis. Thank you for the presentation. It was very interesting.
Um, yeah, Evelyn, I want to follow up a question. There's a question in the comment section, and this goes to all panelists. We don't want to burden only Effie. So the question is, do we calculate GFR for our patients in our facilities to determine the need for dialysis?
It's an important question.
You got the question?
Yes.
Yes, any can be able to comment.
GFR is an indicator of knowing how the kidney, the nephrons filters. So normally someone can have a GFR depending on the state of the kidney. Someone can have a GFR of 30 mils per. Someone can have less than 15. So it depends on the which stage of the renal failure the patient is in. So the lower the GFR means that the kidney is not functioning well, and maybe this such a patient can be put on hemodialysis. You can choose, or maybe kidney transplant for the patient, depending on the modalities that is available for the patient.
Okay, thank you. Effie has dropped. I think maybe she'll join us quickly. Susan, any comment? Unmute.
I don't have any comment. Just to tell Happy thank you for the good presentation. She well articulated all the issues about hemodialysis.
Okay. Nema?
For me, as per now, I have a question,
Okay.
and my question is, yes, in case, okay, let's say the patient is allergic to heparin. So what do you do? What is supposed to be done?
You're saying allergic to what?
During
Can't hear you.
hemodialysis? During hemodialysis, what can be done?
I guess any other anticoagulant can be used with consultation of
Then I can tell you,
nephrology.
there's a wide convenience, so that the nephrologist and the renal nurse, because this care is not like for renal nutritionists only. The nephrologist would come.
Okay.
Okay.
But overall, I can say that
But
the presentation
overall, I can say that the presentation.
Nemo, we can't hear you.
Nemo, we can't hear you.
I'm saying overall, the
I'm saying
presentation
overall, the presentation.
was good, and Effie articulated her points well. So thank you, Effie.
Okay.
Thank you.
Effie, I think you need to now wind up the meeting so that we can be able to close the meeting.
So that we can be able to close the meeting.
Effie, we're waiting for your final remarks.
If we were waiting for your final remarks.
I don't know who muted my microphone. So my final remarks, I would say thank you all for joining today. Thank you for all your comments, but you're still allowed to hit our comment session. And as we continue, this is just day 2, and it's gonna be 2 weeks of learning and good experiences. So kindly join us. We're having this session every 5 to 6 p.m. in the evening. You're all welcome, and let's enjoy this. Thank you so much for today.